I'm Dr. Raghuram Rao. I'm from the Central TB Division, and I'm a public health specialist by profession. And today I'll be speaking to you on the various services offered by RNTCP. Now I'll be talking on the drug-resistant TB services, the TB HIV services, the preventive strategies, the social protection measures, TB notification, and ICT-enabled adherence services that we have under this program. The drug-resistant tuberculosis services was, scaled up, introduced somewhere during 2007, and scaled up across the country. Now, the drug-resistant program has developed very rapidly in the recent years with the advent of newer drugs and newer diagnostic tools, molecular diagnostic tools that have come in. The drug-resistant TB services are provided through nodal DRTB centers, drug-resistant TB centers, where there is a TB ward with 15 to 20 beds of for patients to be admitted, and these services are available at the district hospital or medical colleges in our country. The program is now moving to provide decentralized services. And as we have scaled up, you'll see that the numbers have increased, and in 2014-15 onwards, the numbers have started to increase, and the program introduced Gene Expert, or the cartridge based nucleic acid amplification test. We have around 600 odd in the country now, and another we have achieved in 2017 another additional 500 odd machines are going to come into the program. The program introduced newer drug called as bedaquiline, the newer antibiotic that was discovered after almost 40 years, and antitubercular drug. So that has been also introduced into this program, and more than 700 patients so far have been initiated on bedaquiline based treatment regimens. In the current year, we will also be introducing the shorter regimen for treatment of drug-resistant tuberculosis, and treatment duration from the conventional 24 months is now going to be around 9 to 11 months of duration. The program for drug-resistant tuberculosis identification, the algorithm when we have a presumptive drug-resistant TB case, like new case, even if he is a non-responder or someone who has higher risk of being, and if the clinician suspects drug-resistant tuberculosis, he is offered CBNAT directly, and for especially for and certain key population which are more at risk, these services are offered at the time of diagnosis itself. And when we move to universal DST, we will be offering CBNAT for every diagnosed TB patient. So we have already started that in 19 states, and we will be scaling up in the current year to the entire country, where we will provide upfront CBNAT for all TB diagnosed new cases. Once a patient is offered CBNAT, and if there is resistance, the resistance, since CBNAT gives rifampicin resistance, so only. So once he is diagnosed as rifampicin resistant tuberculosis, he is then offered LPA, line probe assay, to identify the different other drugs that he would be probably resistant to, and based on the second line LPA, the treatment regimen, appropriate regimen is introduced, and if required, culture DST is done for all drugs. Where if the patient is RIF sensitive, he is high suspicion for drug resistant tuberculosis, the patient is offered LPA for the first line drugs also, so that we are able to differentiate if there is monoresistance. So based on the LPA result, if there is INH sensitive or resistance, they accordingly mono or polyresistant treatment regimens are offered. The the various services that are offered through the nodal DRTB centers. The samples, the laboratories may or may not be attached to these laboratories, but the samples are to the linkages that we have under the program. The samples get transported to the higher laboratories at the state level or at the regional level, and the results are transmitted to the patient, and the patient is initiated on appropriate treatment regimen. The newer initiatives, like I said earlier, that is coming under the drug resistant TB treatment services. We are moving to universal DST, where every diagnosed TB patient is going to be offered baseline CBNAT, so that we are able to identify RIF resistance at the initial stage itself. This is called as universal DST. So this has already been introduced in 19 states in the country, and in the coming months it will be scaled up to the entire country. The program is also expanding its laboratory network to upgrade the laboratory to be able to perform second line DST, and also to identify mono or RIF or poly DRTB cases. The program is also introducing shorter regimen for treatment of drug resistant tuberculosis, and the treatment would be reduced to almost 9 to 11 months based on the condition of the patient. And these efforts are expected to give better treatment outcomes. And also newer drugs like bedaquiline and delaminid are being introduced, and in a very, of course, conditionally controlled access program, and which means that it is available only in certain identified centers which have the resources and the capacity to manage complicated cases. And these drugs are also in combination with other drug resistant tuberculosis drugs. The treatment outcomes are significantly improving, and we have already initiated more than 700 patients on this with excellent treatment outcomes that are reported. The program is also scaling up towards decentralizing the DRTB treatment services, and so every district in future is going to have a small DRTB center, district DRTB center with at least 4 or 5 beds that would be earmarked for management of drug resistant tuberculosis cases. The TB HIV services that are provided under the program is provided in a single window approach concept. So the ART center and the HIV testing centers are all integrated and have a very strong collaboration with the tuberculosis program, and the program also has the policy of testing for HIV for all diagnosed TB patients, and for all suspects from the attending or the clients attending the ICTCs where HIV testing happens. The suspects are referred to the nearest DMC for tuberculosis testing, or the sample is transported for tuberculosis testing. The program also provides CPT, that is cotrimoxazole, as prophylaxis to prevent OIs for all HIV TB patients, and ART is started for all HIV TB co-infected patients irrespective of CD4 count. So any patient who is diagnosed of tuberculosis, the PLHIV patient is going to be initiated on ART. Now the program also is offering the molecular diagnostic upfront for diagnosis of tuberculosis in people living with HIV, and almost all the ART centers in this country are linked to a CBNAT machine. If not in the same facility, it is available in the same building. So the services for CBNAT is available for diagnosis of tuberculosis, and it has helped in detecting cases early. The program also, the anti-tubercular drugs that are given, the FDCs are available at all ART centers, and with 99 dots there is adherence support also provided to these patients. I will be talking of 99 dots in the subsequent slides. And the program also has pharmacovigilance services for ensuring that adverse drug reactions are reported in the right manner and are able to be managed. For all PL-HIV who are not having TB, the program is also offering isoniazid as a preventive therapy and to prevent him from developing tuberculosis. After ruling out active tuberculosis in that patient, the program is initiating IPT. 99 dots is a very simple IT enabled tool that is used for ensuring adherence. The FDC blister pack is covered with a sleeve and sealed pack sleeve, and the back side of the sleeve you will see that there are when the patient opens the blister for taking a tablet, like if for example if the patient is taking 2 tablets a day based on his body weight, then for after every second tablet you will see that when he opens the blister for the tablet, there is a number that is a random number that is visible to the patient. The patient then just has to give a missed call to this number, and the software and the system then identifies this as a case of as the patient has taken drugs. So this is something very very nice, and the information that is collected by the software is displayed as a dashboard which you can see on the screen, and you'll see that if the patient has given a missed call on a particular day, the dashboard shows a green color. If the patient has not given a missed call, then it gets displayed as a red color. And if the patient has what happens is, once the patient has missed a dose, an alert goes to his treatment supporter and a reminder SMS goes to the patient that you have not taken drugs today, you have not given a missed call, may kindly take the drugs and give a missed call. So that these help the patient take drugs, and helps the program in monitoring adherence remotely without and it helps the program to prioritize patients to make sure that the patients who are irregular in taking drugs are visited more frequently, are counseled, and all necessary support is provided to ensure that they take treatment. Also, for prevention of tuberculosis, the program has guidelines for implementing airborne infection control measures in the healthcare settings, especially in the ART centers where people living with HIV attend the OPDs and they are most at risk of getting tuberculosis. So there are guidelines available under the program, and the necessary resources based on the health facility. If there is any administrative or any structural changes that need to be made, resources are provided under the program for the hospital to make sure that the health facility is compliant to airborne infection control guidelines. The program also has the strategy of contact investigation. So once a patient is identified, the program also covers and tries to identify his near and dear relatives, his contacts who stay with him, and try to go back and screen those people also for tuberculosis and prevent if they are diagnosed, they are put on treatment, but if not, they are counseled on the preventive measures that need to be taken, and if required, isoniazid is also provided as a prophylactic therapy. These activities are conducted especially in the high risk groups like PL-HIV or slum dwellers, and these are the people who are more prone for getting tuberculosis, and the program ensures that we provide adequate preventive measures to help them getting infected or diseased with tuberculosis. The program also is now slowly going into identification and treatment of latent TB in the country, and in the National Strategic Plan for 2017 to 2025, we have strategies identified for diagnosis of latent TB as well as providing drugs for latent TB infection. And the program also has services and linkages to address the social determinants of the disease. And basically it is, tuberculosis is not just a disease but has multiple facets that are linked to it, and to address the living conditions, to address the poverty, to address the nutritional requirements and the comorbidities that the patient may have. The program has linkages and structured collaborative frameworks like the TB HIV framework, the TB diabetes framework, the TB tobacco framework. There are nutritional guidelines available. So these are various steps that the program has taken to address these issues. In contact investigation, just a couple of points to be stressed is that under the program, all close contacts, especially the household contacts, are to be screened for tuberculosis. And in case of pediatric TB patients, the reverse contact tracing is done. If a passive case is identified in the health facility, a pediatric case is diagnosed, then the program goes back to his house and tries to screen all the adults and the people living in the household to find the index case of tuberculosis. And if there is any active TB case in the household identified, then he is initiated on treatment. He or she is initiated on treatment. And in the also in the contacts that we find in these households, the program should provide special efforts to make sure that at-risk population, if they are there in those households, they are provided the investigations for diagnosing latent TB or rule out active TB, and after that isoniazid is provided under the program as a preventive therapy. In children for less than 6 years of age who are contacts of a adult patient who is diagnosed in the household, these all children below 6 years are evaluated under the program and are after ruling out active TB in them, they are provided INH for 6 months as a therapy, prophylactic therapy. And this has to be provided irrespective of whether they have had a BCG vaccination or no, or irrespective of their nutritional status. Even if they are malnourished, they need to be provided. They are more prone if they are malnourished. The INH is provided at the dosage of 10 mg per kg body weight, and it is to be taken daily and for a minimum period of 6 months. These tablets are provided on a monthly basis to the patient or their relative, and they are expected to follow up and collect drugs on a monthly basis. The most important thing in the contacts is that they should be every month when they come for follow up, they need to be screened for ruling out TB symptoms, and if required they need to be investigated again. The program is also going into newer drugs that are going to be recommended. There are drugs called as rifampicin, which can shorten up the providing prophylactic therapy. The drug has to be taken only once a week for 12 weeks, and that would be enough for preventing him from developing active disease. But these are things that are going to be coming into the program. Thank you for the patient listening to this session.